think we're ready to get started. The first question is going to be related to this news report, and it's going to be very important. We have to do the news report in such a way that we run the tape for a little while, and then we have to stop it, and then we can kind of discuss a little and then start it again, because YouTube won't allow us to play the whole newsreel because that would be a copyright infringement. So we have to follow certain rules. Now, are they going to be able to see that on the screen, or are they looking at the full screen? Okay, so let's go ahead and get it started. We'll play the video.
Dr. Mark Ryan, an anesthesiologist, now facing a felony assault charge, accused of strangling a nurse who challenged him. It happened at Skyridge Hospital in Lone Tree, October 8th. According to this police report, Ryan was turning off patients' vital sign machines in the recovery room because of the constant beeping. But nurse Beth Duche told the doctor to stop turning the machines off. Police say Ryan then grabbed her by the throat and squeezed Duche's neck. She lost her function to breathe normally. She was seeing stars. She told police she thought Ryan was going to kill her. Another nurse witnessed the assault, saying she saw Ryan.
Let's pause it there. Okay.
All right.
This appears like a rather extreme example. However, and anybody out there, the phone lines are open. So just remember to let them, you might want to put that up when you get a sec to do it. Has anybody ever witnessed this level of assault?
No, not firsthand, no.
No? Have you ever seen a couple of surgeons or a couple of physicians themselves go toe-to-toe?
Yes.
To where they were just chest pounding, or actually landing blows on each other?
They had to be physically restrained from each other.
Mm-hmm. You too?
Not quite that far.
Not quite that far, so just the bowing up. Mm-hmm. The bow ready to go at it. But you went even further. You wanted to, can you tell us with respect to obviously not disclosing where this was or who this was and all that stuff, can you tell us about the story?
It was a difference in professional opinion about vent settings, believe it or not.
This was alarms on the bed.
And it was, one was the surgeon of record, and the other was, I would guess you would call them an intensivist back then. I guess you're a hospitalist now, whichever where you're from, part of the country. But there was quite a difference, and one surgeon was, the surgeon was telling the nursing crew, don't let anybody change this. The other guy was coming in and changing things, and unfortunately the nurse got caught right in the middle of it, which was a really tough situation for her to be in. But these two, the surgeon waited around the corner, and sure enough, the intensivist came and was starting to manipulate the vents, and the surgeon appeared and said, I want it set that way, don't touch it. The intensivist says, you're killing the patient, I'm gonna put it this way. And the argument ensued, and they had, there were other people with the intensivists, so they stepped in between the two of them. Mm-hmm. And it cooled down rather quickly, but I thought for a second, that there might be something going on. But they eventually both backed up away from it, and I guess cooler heads did prevail.
Good. You? Tell us your story.
Oh, well, I don't have one specific story, but I've definitely seen in the ICU particularly where multiple people are managing one patient, but there's not one person who has been deemed the in-charge person, the exact same kind of scenario, different ideas about what should be done, whether it's vent settings or blood or whatever. And storming offs, and you don't know what to do because you're often caught in the middle, just like that nurse was.
And you're there on ECMO, obviously. And so that can create a lot of stress because you too have an opinion, right?
Right.
You certainly have, and of all the people there, you probably have the most experience in that circumstance, and no one's asking you.
Right.
And I find that always to be so crazy. Okay, can we continue with the tape?
Yeah.
Oh, Praveen says, hello, Joe, Tammy, and Mike.
Hello.
Hello.
Oh, look, and he said John's gonna call in. Okay, John, great. John, and hi there. Praveen.
Go ahead and start.
Yeah.
And squeezing Duche's neck very violently, and her feet were dancing. Reached by phone, Ryan told us, "I think it will be easy to show there is no intent involved."
Okay, pause it there. No intent to not kill her? No intent to what? No, there was no intent to what exactly?
I guess he's maybe saying it was just like a temper flare.
But no intent. Like when you put your hands around somebody's neck
He wasn't planning to kill her, I guess.
and but you have somebody's
So we think I can come up
I mean,
with,
has
yeah.
anybody ever seen, like, not that I like to watch morbid movies, I really don't. But I mean, they do exist, okay? And I have seen them, And when people get hanged, their legs are kind of doing like this for a little while until they just sort of slow down and they stop eventually. But they're trying to, it's a survival mechanism.
Right.
So I would imagine that if her legs were dancing, there was probably, I mean, you could perhaps argue heat of passion, maybe, but no, I think the intent was sort of obvious,
Yeah.
Yeah.
No doubt.
and that is, either he was only intending to tell her how nice she looked that day, I suppose.
Make her hush. I don't know.
Maybe they needed. Maybe he wanted her to alarm.
He obviously
Silence the alarm. He was silencing alarms.
Yeah.
obviously didn't want to hear her opinion. That's for sure.
Yeah, that's for sure.
So
Clearly not. And a good way to stop somebody from talking is to choke the hell out of them so that their feet are dancing. Okay, let's finish that video.
That was the end of the news story.
Oh, that was the end of the news story? Okay. So that's one twist to all of this. Okay, we observe this very unprofessional behavior in a place that is supposed to be above that, really, at the end of the day, right? We're supposed to be above this.
right.
And I think that the general public and the patients somewhat expect that from us, whether it's us or whether it's physicians or whether it's whomever else.
Right.
But really the question is, do you have any stories, and I have a few, of working with surgeons, male or female, who were just so disrespectful, rude, and dismissive almost of you as a professional in the room, that your job was unbearable. You hated to go to work if you had to work with this person.
Mike?
I don't think any of them ever got to that point with me personally. However, I did see evidence of a surgeon that I knew who was very rough on the surgical support staff, scrub techs in particular. And, I think that as tough as our job is, I think the surgical techs have it really, really rough because they're the first line helper of the surgeon. And not only do they tend to help the surgeon, but there's always an assistant, a PA, a resident, or something like that. So they have very, very difficult jobs. And I do know that this person was responsible for quite a few people leaving this institution. And this surgeon almost reveled in that. And I always thought,
What a great thing to be proud of.
yeah, and I felt terrible. And these weren't new technicians. I mean, they had been around for a while. There was just something about him that his level of perfection that he expected from someone else might have been better turned around and looked at upon himself.
You just brought up a very good point. So let me interject this if I can before I ask you about your own personal experience, because I have a lot.
I want to talk to him about this too. I have
Yeah.
an opinion about this.
I do. But my opinion is, and you may have the same one, I have found over the years that it's the least capable of the group that is the meanest and the most hateful and the most projecting failure onto others. I don't know what the term would be for that, than the ones that are just really good at what they do. I found them ones that are really good. I mean, the ones that are really good, good judgment, good hands,
Right.
great outcomes, have more cases than they could ever possibly do. Everybody likes them. Everybody respects them, treats people with respect, treats everybody that way.
Right.
They're the ones who are the best.
To work
The
with.
ones that are marginal or okay, but believe they're the best, but they're really not, and we all know it,
Right.
are the worst.
Yes.
And when it comes to these offenders, there are some that doesn't hold true 100%.
Right.
But I have certainly found disproportionately that more surgeons who are not as capable as others tend to be the most
Yeah.
volatile, the most
Right.
accusatory towards others, and the type that don't manage difficult situations effectively.
Right.
I agree with
What
that.
were you gonna say? Sorry.
I was going to say about the surgical techs, don't you think sometimes too, it's not just a level of perfection that is expected, it's almost like picking a fight because
Oh, Tammy's microphone is too low. We're getting complaints from online.
Oh, do I
No,
need to move
no,
it?
no. He's just got to turn your sensitivity up.
don't you think
Thanks,
that,
John.
Thank you, John.
that sometimes they just want to make this person look incompetent, not that they necessarily are?
I've noticed that before. Perfectly capable, very experienced in CV surgery.
Oh, yeah.
And maybe even works with a particular surgeon enough to know their routine, but whatever it may be, they can do it, and another person that they like can do it the exact same way, but the person that they don't like, they're going to
Bite at them.
criticize.
Just yes.
you know,
And I find that crazy.
it's bizarre.
Because this isn't a personality contest.
Well, it just
This
delays your surgery. It distracts. I don't
Well, it
understand.
does. It
It's
does
not
all of
productive.
that. No, and
We
it's
all-
not positive for the patient.
No.
No.
It doesn't help the patient because that surgical assistant or scrub assistant,
can
tech,
get
scrub tech,
flustered.
whatever you want to call it. Well, but they become. I mean, you become demoralized.
It's distracting
You're
too.
demoralized.
The emphasis is not on the heart and what you're trying to fix and work on. It's what's going on over here.
Right.
And it just is. It's bad. Very,
Yes.
very bad.
Yes.
I've also found, Joe, that
Do I need to
and you spoke about the surgeon's capability as being a little bit of a precursor to this type of demeanor and this type of behavior. I also found that the very young surgeon and the very old surgeon who's about to be done fall in that category too, but for different reasons. The older surgeon is like they're probably about to be the last few cases they've done in the last year. They've probably been tired of seeing 1,000 different perfusionists coming through and doing their cases for them, and they're ready to hang up, their work for the rest of their lives, and they're just tired and they just can't handle any change anymore. Conversely, the brand new surgeon who may not be quite so sure of themselves is waiting for those board results. They're on pins and needles. They just got married, they got a baby on the way, and their whole life is dependent upon when they get that letter saying you passed your cardiovascular boards. And they're the ones that tend to be on a point of making their reputation known, which may precipitate that type of behavior more than someone. The person that you talked about who's the perfect one is a surgeon who's been doing this for about 10 years, pretty much seen it all, knows what to do, knows that you know what to do. That is the best team. That's the best team.
Oh well, I've seen surgeons. Certainly, I've had my experiences I was doing a case, and the Slido, by the way, go to that Slido and let's see what those. In fact, if you want to put that, if you can put it up within the frame, like I don't know if you can do that or not. If you could put Slido up and see if we've got any poll results yet. But I was doing and I've got several examples, but this one particular, I was doing a case for this guy, and it was the first case I had ever done for him, and I was working for that company that we both are aware of. I won't say the name of the company, and I was down in this city, and I end up in this hospital doing this case for this guy I'd never done a case for before, and. I went up to the guy to introduce myself and to talk to him, whatever. And he wasn't one of those that was brand new, and he wasn't one that was ready to retire. He was probably 20 years, maybe 15, 20 years into his practice, and he actually had some reputation. He had done some things. He had written a book. Hint. And I go to introduce myself. And say, I don't really care who you are. Yeah. Just go over there.
Yeah.
So I'm like, okay, well, nice to meet you too. So I, did my thing and handed the lines up. And of course, what I found in that case, and I've seen this happen before too, and it could go either way, but more often than not, this is not the case. But in this particular case, it was, where he had his little favorites of minions. And so even the scrub nurse was being a jerk.
Yes.
And anesthesia was being, huffy, and the circulator was being whatever. And they had a balloon pump in, and I could tell the balloon pump was not timed properly. So I just, figured I'd go over there, and it wasn't timed properly. I went over there, and the circulator came over and said, "What are you touching? What are you doing?" I said, "Well, I'm going to adjust the balloon pump." "You don't touch that. That's my job. You need to go back over there." I'm like, okay, well, this is going to be a great day. So, but I'm committed now, patient's on the table and the chest is open. So I'm like, I can't just leave. So we do the case, and the case is over, and he was fairly fast actually. So, technically he seemed capable, but we come off pump, and I was, trying to kind of get my bearings to make sure everything was okay. And I noticed this movement, and I could see and I looked up, and he was standing there with the venous line in his hand, shaking it at me. And I was like, what do you want me to do, And he said, "Take the line." He was like, "Take the line." So I'm like, okay. So I reached up and I took a clamp and I opened it up and took the line, put it up on the thing, and I was thinking to myself, what happens now if we need to go back on pump? I'm not familiar with this hospital. I don't know where everything is easily. I'm as oriented as I'm ever going to be, but I knew there was another tubing pack, so I figured it out. But I was like, man, this doesn't seem like a really wise way to do this. So I gave volume, chased volume, did whatever, and just takes the arterial line out after the protamine and everything else. Same routine, takes it out and he's shaking it at me. And now it's blood kind of flicking around. So I'm like, okay, I took the clamp, took it, put it up, pushed the pump to the back, waited, closed the patient, and he breaks scrub and he's leaving. So as he's leaving, I walked up to him, got in his way, so he could not go through the door. And I said, "Dr. So-and-so, I just wanted to tell you it was very nice having met you." Put my hand out to shake his hand. And he said, "What do you mean?" I said, "It was very nice to have met you." And he said, "What's your point?" I said, "I'm not coming back. This is the last case I will ever do here. So if you need a perfusionist for either your next case or tomorrow, you know who to call. Have a nice day." I left that pump exactly the way it was. Patient left the room in stable condition, got to the ICU. I left the hospital, never went back.
That's unbelievable.
That's how I dealt with that situation. But I was far enough along in my career.
Right.
Right.
I had the confidence to say, screw you.
Yeah.
If I get fired for this, I don't care. I'll have a job tomorrow someplace else. Didn't care. This is not worth it to me. But what about the guy, and if you're out there again, please let me know. What about the guy who is younger in his career, takes a job in a smaller community environment, is working maybe with just a couple of guys and himself, just got married, baby on the way, bought a house that he really couldn't afford, and now this is what he's confronted with, and he just can't fathom. He's just to the point of having ulcers, having tachycardia, having atrial fib, having to go into the hospital and work. What do you do? What would you tell somebody out there that was in that situation, whether it be a perfusionist or whether it be any other medical professional? You got a lot of experience, Mike.
Yeah.
And our younger colleagues may not know exactly what to do. What would you do?
I tell you what, time is the greatest healer of all things. What you have to do is go in and do every case, apply your professionalism every single time, ultimate professionalism on these types of situations. Be courteous, be in the room when the patient's in the room. I found that if you do things to the utmost professionalism, that all of a sudden, they don't have anything to get angry with you about.
Well,
Because
or
you've got it down.
even if they do, they can't, it's not anything that they could actually complain about.
Right.
It really comes down to, they'd have to admit they're being difficult because
Right.
there's nothing that they can say. You were there when you were
Right.
supposed to, you did everything you were supposed to, everyone witnessed you being courteous, doing your job,
Right.
not being unprofessional in any manner. I do the exact same thing
That's
when
what
I'm
I do.
confronted with things like
So
that.
kill them with kindness.
Kill them
Well,
with professionalism.
Professionalism.
Right.
Kindness, I mean, it probably depends on your personality, but you kill them with professionalism for a certain amount of time, kind of establish that this is who you are. And if they continue to act that way, then I think you seek out, support, whether it be from your colleagues or from your administration, and see what kind of support you can get there. Because if they're picking on you like that, they probably do that to lots of people.
I don't know. They probably do, but I've been amazed at how long some people who act like that, and I've got other stories, but
Yeah.
this is about solutions now.
Yeah.
But there's been people that have been through this, and you're right, it is a lot of people that they do it to, but there's a lot they don't, and it seems to be just enough to where they continue to survive and able to, it's almost like they're enabled by administration.
They are.
Who's calling?
Hello?
I'll bet it's John Ingram.
Yeah, is this John?
John,
Yeah, hold on, let me put John.
You guys hear me okay?
John, what's going on, bud?
Hey, John.
Hey, good to see you guys.
Yeah.
Talk to us. Tell us what you got for our, what solution do you have? And can you put up the poll, see if anybody answered it?
I'm trying to get that up.
Go ahead, John, we're listening.
Well, Joe, as I always say when you invite me to be on the panel is when you've been around as long as Joe and I have, you can tell a lot of stories. And mix in with that fact that I've been a traveler for the last 5 years, I can tell you a lot of stories. But I wanted to call because you guys hit upon something that really is a very valuable piece of information. You have to display your confidence, but you have to have the years and experience behind you. So for a new person listening, what I wanted to say was, and I did this for 12 years of my career. I was the only perfusionist at my hospital. There was one cardiac surgeon. It was me and him, one or two anesthesiologists, and he was brutal. So the waking up every morning, feeling like you're getting ready to get kicked in the stomach, day and night was there all the time, and you had to get out of bed, go to work. And what your panel just said there about being absolutely professional is very, very key. Most of the time, over time, you'll win them over, but they still are so wound tight that sometimes you don't. So what I wanted to say was, if you're within your first 5 years and you're having difficult surgeons to deal with, the number one thing that you have to do is be the best, absolute best perfusionist you can become. Okay, so that doesn't only mean what these guys said is absolutely correct, being absolutely professional. You must go home every night and find an article to read. You must call perfusionists on the phone and discuss problems you're having with the lines that day, or the flooding, or the venous drainage. Educate yourself every single day to become the best knowledgeable, because knowledge is power. That surgeon and that cardiac team that you work with, when you're asked a question, hey, what's going on back there? And you come up with more and more intelligent answers, you will gain their respect. And that professionalism and that professional respect, you will begin to gain. So that is the first thing that I think new grads, and I say new grads meaning less than 5 years is a general term. You have to become the most educated, knowledgeable perfusionist you can become. Then you will begin to turn the tables, because when you speak, people are like, wow, that was a very intelligent thing to say. Maybe this guy really does know what he's doing. Now, once you get past 10 years and things, Joe, I could tell you stories the same thing. You know, one time a surgeon was yelling at me and all this and that, the other thing, and I was doing everything I could to be doing it right, but it was always one thing after another. And finally I said to him, you know, doctor, we're all pushing this wagon in the same direction. You understand what I mean?
Yes. Yes, absolutely.
We're all working towards the same goal, right?
Exactly.
And these guys are acting like somehow you're there working against them. And they're constantly barraging you. Why are you doing this? Why didn't you do that? And sometimes you have to take it. But after you gain your confidence, and you gain your confidence by becoming the best, most knowledgeable perfusionist you can become, then you gain confidence. Now you can start drawing a little bit of boundaries. You don't have to take this forever. I wouldn't tell anybody to take this forever. You have to stand up for yourself at some point. That point is far down the line. Don't get me wrong.
Yes.
It's far down the line. You have to take a lot. But at some point, and I have stood up for myself many times, and I've also taken it before that point happened. And this is one thing that people can say, is remind the doctor that we're all here pushing towards the same goal. Yes. And the doctor will usually stop and think to himself, yeah, I guess that is true, isn't it? You know, that these people aren't all here working against it. Why am I treating them this way?
But John,
and that's just one thing.
Right. But John, in all seriousness, you know, that takes a certain, it takes a certain maturity. And I know when I first started in this industry, I was young. And you still see today, you know, we have perfusion school graduates of 22 years old. You know, what reference, unless they were in the military, what reference do they really have about people really being mean to them? And then, of course, you have this very super sensitive generation that we're dealing with. So, you know,
well, that's something that should be taught. It should be taught.
Exactly. Very good point. It's not taught. It's not.
I had lectures about professionalism and dealing with difficult people. And
you did? Back then they did it. Not that it was that far back then, but they don't do it now, I don't think.
Yeah, I don't know if they do, but our particular person who was doing that then made a point to talk about that.
Was it Terry or Debbie?
No, it was Doc. Doc did a whole talk on being,
Rose.
Yeah, on being
that's
professional.
That's an oxymoron when it comes to him, but that's another story.
Being professional and learning how to handle difficult people. Yeah, because it's going to be a part of your job. And he approached it with about handling stress, because you're dealing with a difficult person. You might be in a stressful situation, you know, especially during a crash, or even if it's not a difficult person, but during a crash, not everyone's going to behave at their utmost.
Right. Yeah, but
best.
And I think there's a difference between, it's almost somewhat forgivable when these guys go off the rails, when it's really a disaster.
Sure.
And I think that's that's understood in some ways. We're not talking about that. We're talking about the person who is just malignant.
Right.
And he maligns you for no good reason. And John, I think to your point, I just think that it takes a certain level of maturity, which you can only get through experience and time to be able to deal with that. But what do? Let's say they do everything we just suggested. You are the consummate professional. You try to let it roll off your back. You're miserable going to work. the person is just toxic to you. It's hurting you. It's hurting your sense of self. And look, I mean, Perfusion used to have, and I don't know where it is today, but it used to have such a high suicide rate that they actually had a hotline that AMSEC had
I remember that.
with a psychiatrist that would answer the call if you were contemplating suicide. Perfusion had at one time a higher
Through
suicide
AMSEC,
rate than air traffic controllers, and they were pretty high.
Wow.
So, I mean, I personally know two. One who ran a bag of cardioplegia in himself in this car in the parking lot, and the other one who shot himself in the head and killed himself.
Right.
Over what we're talking about here. This is what it was about. So this can have profound impact on especially a younger person. But do they say to their loved one, their wife, whatever family, whatever it is, or to themselves, they're by themselves, it's easier, this is not worth it to me. And because what makes any place change? You hire people and they leave. You hire people and they leave. People aren't staying here, and that's costing the institution money.
Right.
When you look at lawsuits, what does the jury do to make the company or any other company never want to make that same mistake? They give a big award.
Yeah.
Right.
They give a
You
big
have
settlement.
to hurt the pocketbook to get an effective change.
Right.
So, I think trying to have the discussions, trying to meet with the person that you're having conflict with in their office makes sense. Trying to say, like you did, John, we're all pushing towards the same goal. We all are here for the patient. I'm trying to do the best I can. Can you please, I want to be treated more respectfully just as a person and a professional. I'm really doing the best job I can. But at the end of the day, if it doesn't change, even though you may feel, I'm not going to let this person make me leave, for your own sake, my recommendation, find another job and leave.
Right.
But
That's what I would do.
to the point, especially on a new grad, a younger person who maybe doesn't have a lot of experience in this, I also think you need to take it for a little while because you need to see.
Of course you have to take it. I wouldn't say the first case, but if this goes on for 6 months or a year, I think that's long enough.
That's long enough.
Yeah.
And once again, you spoke generationally about the new perfusionists coming in that maybe not have went through the things that we did. Being as old as I am, I had a very strong father. I played athletics, so I had coaches that rode me and everything like that. So
You
I
had
guess
that experience.
I kind of got used to it, and it would either, and they always used to say, what doesn't kill you makes you stronger. And that's basically the way things were done back when I was growing up.
Yeah.
And, it made me stronger. And I really am concerned about the perfusionists coming out today that they may get these seminars concerning this, but unless you've felt those feelings and had somebody come down on you, it's real difficult to handle.
Yes.
The most, to me, as I was coming out, I told myself, and I tell young perfusionists, never lie to the surgeon. To say that you did something and you didn't do it. If you did something and you did something wrong, own up to it. They respect that so much. One of my first years out of into private practice, when I graduated, I was on case, on pump, and we run up the arterial line, made the connection, and then all of a sudden air was getting in the arterial line and coming down. And the surgeon would go, Mike, what's going on? And I thought for a second, and the only thing I could think, which was the most honest thing I was feeling at the time, I said, I don't know, sir, right now, but when I find out, I'm gonna let you know, and I'm gonna correct this. And what had happened, my bypass line had clicked off. And it started draining. I said, here it is. And he goes, good save. That one thing there, when I told him, and I was honest, I said, right now, I don't know, but I'm gonna find out what the problem is. I mean, from that day on, he knew that I was going to communicate with him, that I was going to be honest. And
They could trust you.
They could trust me that I was going to tell them what was going on, and that I was going to admit your mistake if you made it. It's your mistake, you made it. You better admit it. And and that type of stuff just starts building that respect, and with respect comes trust.
Now that's another very good point. You bring up a very good point, and I'm going to take this down a little different rabbit hole. Would you imagine that a younger, less experienced, or even maybe a not older, but a little bit older, but not as experienced, because you can be older and have been in this profession for a while, but depending on where you work, depends on what your experience is, right?
Situational learning.
Sure. And you have a surgeon who is what we talked about earlier, malignant, toxic, mean, very accusatory towards everybody. And there is an issue. Can you see an opportunity where a perfusionist would be hesitant to want to take, you have to, I know you have to, and I'm not saying that they shouldn't, but can you see where you would be, because now this could be the end of my career, even though the problem that happened didn't result in a patient morbidity or mortality.
Right.
It was just an error in something, whether it be an occlusion or a connection or
I didn't worm sumina, whatever it is.
It is. And they'll not tell the truth. They'll not just be transparent because they're afraid. And so I think the toxic environment doesn't breed
Honesty.
what you're talking about. It instead breeds. So their behavior is negatively impacting, in my view, the overall care of the patient. That's what I think.
I think it
Could definitely lead to that.
Yeah. it can.
especially if the malignant person is trying to get you out of there, because then they just start making a little list, and even though it's a little list of nothings.
The little grievance page.
Right.
Whatever
Yes.
it is.
No, I've worked in that environment. Grievance page after every case. Every single case, there was at least 10 things.
You're doing good here. I mean, your grievance page is only a couple of pages longer. So you're doing really good.
They weren't all about me.
I'm
just
sorry.
saying.
I thought they were all yours.
No, I'm just saying in
okay.
general. So
Right.
some people don't want to be pleased, and so that would be very intimidating,
But if
especially
somebody
if
hates you that much and wants to get rid of you, do you just sit there and stay and take it until hopefully they're older than you by a significant amount and they die, and then you instead of go to their funeral and rejoice as opposed to be reverent, or do you just say this isn't worth it? You don't want me here. You hate me that much. It's not worth it. Can you just treat me decent? I'm going to look for another job.
Yeah.
And let's just try to separate this in some way that I don't leave here feeling any worse than I currently do.
I think it depends on the person and the personality. I mean, I think the more mature I became, the less personal I took it. Just thought,
Me too.
that's just who they are. I'm just going to do my best job that I can do. But it really depends on your personality, and it depends on the day. Some days you can go in there and you're not having a great day, and then that gets piled on. You're like, this person's the worst.
Right. Right.
But I don't think it's limited to the surgeon. You have,
Oh, yeah.
you
that's not
know,
just that.
Yeah, you can have nurses that can act like that.
Yeah.
We have colleagues. We have other perfusionists who can treat you like that.
Yeah.
They'll come in the room and they'll just start
Changing
tearing
everything
you
you've done.
apart
yes,
Right.
just, yes.
in front of everybody.
Yes.
And and usually everybody in the room is just rolling their eyes because this person does that all the time.
Right.
But
But a
it's
horrible
still-
supervisor or
Yeah.
coworker can be just as damaging.
Right.
And it's humiliating, and that's not really what you want in a caregiver in the middle of a case, is
Right.
for them to feel humiliated.
Right. I guess, and we'll wrap this up with this Mike Sound AMSEC line. David, what is? Can you just?
What's going on?
I don't
Sound?
know. Magic is asking me for something, and I don't know what it is. Magic, please, just
But I think any job
Text
is going to have
me.
difficult
Oh,
people
yeah.
to work with. It's just
I don't know what he's asking for.
in our particular situation, it can be in a very high stress situation, and you don't perform well if you're afraid of the people you're working with.
You're right. I mean, when you're
Not
there,
to your best.
You know, our job it's different than some jobs. It's just not a personality conflict. There's
Right.
there's a third very important person in the whole mix. It's called a patient, and you have to just make sure that you're doing the right thing.
You're doing the best you
Everybody's
can for the patient.
doing the best that you can, and you know, a lot of times at the end of the day, I was one of those cases, and I said, well, you know, I did the best that I could.
Yeah.
So I'll tell you a funny story. We'll end on a funny story.
Okay.
When I first started in this business, I was in University of Arizona and Tucson Medical Center in Tucson, Arizona. And the surgeon was, I'll never forget him for as long as I live. And his name was Dr. Sabib. He was Iraqi, okay? And it was very funny to talk to this guy, you know, because it wasn't the patient developed something, you know, and he had this very strong Iraqi accent. And this one day, when I was in training, we had to scrub. So we alternated, pump case, and the next day you had to scrub. You had to learn how to take vein
Right.
with an open harvest. You had to first assist.
Right.
You had to. We put the radial arterial line in. We put we even put the swan. We floated the swan. We had to do everything, and it was a great experience. I mean, I got to do things. Now I wasn't any good at it, but I got the experience, okay, of doing it.
Right.
I certainly learned, I think, early on that I was never meant to be a surgeon. But with that said, he was such a funny little character that he was scrubbing at the scrub sink, and he was walking towards the door, and he slipped and fell. But he didn't brace his fall. He literally fell, and he still had his hands like this, and he was like on his backside, like kind of half like this. So I went over to him and I said, you know, let me help you up. And he goes, no, you do not touch me, you idiot. I'm sterile. Really? How? Really? Okay, you know, I'll let you get up. But so this one day we're doing this case, and of course we had no cardioplegia. This was intermittent cross clamping. And he does this big, long anastomosis. And of course, it had to be pretty fast back then, you know, because they would fibrillate the heart, put the clamp on, do the distal, take the clamp off, defibrillate the heart, get it beating again, and then wait a little while, and then
Do the next one.
fibrillate the heart, do the next one, and then do the proximals at the end.
I
It was-
bypass this
Yeah.
long.
It was very long. Yes, it was very long. So he did this big, long anastomosis. And I was just a kid. I mean, I was a kid. And anyway, so I cut the proline, but I cut the knot. Okay. So you're supposed to leave a long tag, but I cut like right on the knot. And he looked and he said, oh, no, Joe, no, you have to leave. You have to leave. And Billy Applegate was my instructor. He was there. And he goes, Billy, Joe cannot come back until he goes to the eye doctor. So I had to go to the eye doctor. We're doing another case, and I got new glasses for free because he paid for them. I go to another, and there was nothing wrong with my glasses. I just was nervous. So we're doing another case, and he said something I didn't understand. It's not that I didn't hear him. I didn't know what the hell he was saying. And he gets upset. He says, Billy, Joe cannot come back until he goes to the audiologist. So they send me off. So I go to the audiologist. And I'm like, dude, just give me a fake hearing aid, okay? Something. There's nothing wrong with your hearing, you know? But he's not going to buy it, dude. You got to give me something, you know? So for the longest time, I actually did, for a couple of days, I had a little, you know, model of one, and I would wear it. And he thought everything was okay then because I could hear. So in the time that I was with him, I got my eyes checked and my hearing checked. Still got thrown out of the room, I don't know how many times, because that's what they used to do, is just throw you out, you know, be running the case, and the PCO2 would come back 28. And why is this? Why is this? What are you doing back there? Billy, take over. And you need to leave. You need to leave. Go read the book. And I would get thrown out. So I got thrown out of the room constantly. But he wasn't mean about it. He was just Iraqi about it. But that was fun. But I got a good I got a lot of examinations. I got checked for everything.
Yeah.
Mm-hmm.
Yeah.
But those were the good old days.
Yeah.
You
It's
know?
a little bit different.
The internal paddles used to be able to charge up to 400. They didn't have restrictors on them back in those days. You had to make sure it was on 20.
Right.
You know, and the E4M monitors and our heater cooler had a hole this big for ice, and we would have to take the ice and stick it in there. It would take us forever to get the ice in the
Why?
heater cooler. That's just what we had. It's what we had. I mean, I was using a Travenol bag. You know that big bag that's in the Cooley Museum? You know, with the Brillo pad? That's the oxygenator I trained on. It was 1977. I was kind to you. Don't be so mean to me.
I'm just
See, this
listening.
is a hostile I'm calling a hostile environment. All right. So we need to get to the next video. Okay, John wrote that's my word, but they are not. I need some insect suicide line phone. Oh, okay. Somebody texted me that they need the AMSEC suicide number because of our program today. And that was not very nice. Again, that's also very mean and hostile, and I'm affected by it. I'm gonna need a safe space, or I'm gonna need, what else do you get now? Safe space, and you have do you get cuddle bears at work now too?
I don't know.
I think we should
I don't
develop
know.
the cuddle pump bear. We'll call it the cuddle pump bear. And perfusionists, when you graduate from your perfusion training, you get a cuddle pump bear, and you take it with you. When the case is bad or somebody's being mean to you, you just kind of hug it. Yeah, and it'll take a lot of that stress away.
Would you rather have that or the damn it doll? Where you
How about an effigy of your surgeon with an 11 blade and just stab it. Okay, so let's go right
What were the
into
results of the poll?
results of the poll. Have you
had to
ever
close
worked
that one.
with a horrible surgeon? 5 people responded, 100% said yes. And I wasn't even one of the 5. Very good. Okay, so let's go to the next video because time is just flying. We've blown through 45 minutes.
Wow.
It goes fast. Okay, this one is even better because this, I think, the jerk of a surgeon, jerk of people, if you're really young, it bothers you, but I think all of us here, I'll tell the youngsters this. My young colleagues, I don't mean youngsters disrespectfully, my younger colleagues. It all irons out after a while.
Right.
Don't even let it bother you that much. If you get to the point where somebody's treating you that badly, either do one of 3 things. Obviously go through proper chat. First thing would be I would address it with the person personally. So let's give a really good message, something that is meaningful. Address it with the person personally. Sit down and say, look, I need to talk to you. And explain it. Be transparent.
Not during the case.
Not during the case, of course not. In their office. And do it in a non-emotional way. If
Yeah,
that's at all
maybe
possible.
if you are emotional, you should wait until
Yes.
tempers have cooled.
Yeah,
Right.
so you're cooled down, right. Second, if that doesn't help, you have to go to administration. You have to move up the chain and say, look, this is how I feel. But again, you have to be accurate, transparent, and respectful all the time, or people will not listen to you. That's the second thing. And the third thing is find another job and leave. Life's too short.
That's right.
Really, at the end of the day, that's kind of how I feel about it because I don't think tigers change their stripes too often.
Not unless they're made to.
Even then they don't. They just have a vendetta. And you don't need that kind of environment. Okay, so our next video.
And we're hiring.
And we're hiring.
All these people have something in common. They went to the same surgeon, a surgeon some are calling a sociopath, and they are telling stories of botched operations that left them with agonizing pain. Now, that surgeon has just been indicted for aggravated assault with a deadly weapon. What was that deadly weapon? His surgical tools. Here's Lisa Guerrero's investigation.
Okay. So, it's one thing to work with a surgeon or people that are jerks. But now, by the way, this guy's name is Christopher Dunch. I won't tell you what happened to him until we'll play the rest of the video so you can see what happened to the guy.
Okay.
But what do you do when you're working with a surgeon who no doubt in your mind, is maiming and killing their patients? Because I've seen it.
Yeah,
You've seen it.
I've seen it.
You've seen it.
I've seen it.
Let's play this a little more.
They showed up struggling to walk, some limping, some using canes, and others unable to walk at all. These 9 people are speaking out to Inside Edition about the man they say ruined their lives.
He's a monster.
Drug addict, a psychopath,
Killer.
And they're not talking about a hardened criminal. They're talking about a neurosurgeon.
Oh my gosh.
Now, I have several questions. One, let's do a poll. Open the poll up. Open a poll up? There's a poll. Current poll is, where is it? Did you activate the next poll?
No, you have to do that from your.
Okay.
It's down, scroll down.
Okay. Oh, I forgot to open this one. Okay. Well, I'm going to leave this one up, and then I'll have to write another poll. But this other one, if you have worked, of the 5 people that answered the previous poll, the follow-up is, what did you ultimately do about it? I forgot to turn that on. So go do that poll quickly, and then I'll open another poll about this particular situation, which is, have you ever had an experience with a truly bad practitioner, whether it be surgeon or anesthesiologist or intensivist, that without a doubt, should not be practicing medicine, or certainly practicing the field they're practicing, the discipline they're practicing. Okay, so I'll write that up, but go ahead and answer this poll, and I'll create that poll. Tammy, Mike, talk and see what you can do while I write this up.
Can we play some more video?
Yeah, you can play some more video.
Our next best doctor, it's neurosurgeon Dr. Christopher Dunch.
In commercials, Dr. Christopher Dunch calls himself the best neurosurgeon in all of Dallas. He specializes in relieving back and neck pain.
Then they come back to me to discuss surgical options.
But these folks couldn't disagree more. They say he's a butcher and a drug addict who maimed them during surgery.
Wow.
Okay.
Well,
What do you think of this guy?
the situation that I was in was not a neurosurgeon, but an orthopedic surgeon. Had a lot of lawsuits against him. Was now relegated to working at a very small hospital, and we were doing just self-saver work. Thank goodness. Thank goodness. Was not a heart surgeon. It was an orthopedic surgeon. I did not want to do the case. I was told that I had to go do the case because that's the way things were done back then. Fortunately, it was the case went well. You know, situations like this always get me because these can't be the only 11 people he worked on.
That's right.
He's had to have had some successes.
Well, I think what's important to make a distinction here, although the results could be the same, but is this a person who they really are doing the best of their ability and they're just not any good?
Yeah.
Or is this a person who's doing inappropriate things during surgery, dangerous things, maybe not taking it seriously, whatever, and having these kind of results? Because I think they're both horrible, but I think the one obviously that is not taking his work seriously is the worst. There was just a news story about a dentist this past week.
I saw it.
And I mean, that person, he might be a good dentist, but he did some horrible things while his patients were vulnerable and they trusted him and, you know?
Well, if you will, please, I both agree with you and disagree.
Okay.
For me, okay, so I'm going to skip this poll, but I'm going to turn on the one that I just did. So I'm going to cancel that one, but we're going to go here. Have you ever worked with an incompetent surgeon? Yes or no? Go to slido.com, perfweb31. It's the active poll. Let's fill it out. Come on. Okay. It doesn't matter to me. I mean, maybe I can not be as disgusted by a person who is really trying and just doesn't have good judgment or doesn't have great hands and probably really shouldn't be a heart surgeon. But at the end of the day, if the outcome is the same, whether it's that person or it's a person who may be pretty good, but because they're doing coke and drinking and leaving in the middle of the procedure and coming back, or just not engaged with what's going on, the bad outcome is all that really matters at the end of the day. You know, I think if I feel like if I were a truly bad perfusionist and I had made a couple of errors that resulted in some bad outcomes because I just wasn't very good at what I did, I would want to think that I would reconsider my professional pathway.
But don't you think a lot of times, probably some people do, and they move on to other things, but don't you think with some of these doctors that we're maybe alluding to, perhaps this one as well, doesn't realize they're bad? There's always an excuse why the outcome is not good, and it's not because of their skill level or their judgment.
And you don't think that that's just self-delusional?
No, I do.
I mean, it's
But
so
for them-
that takes active effort. You don't start off immediately mitigating your circumstances and blaming it on the bad patients that you're being sent or just
The staff that you're
bad
given or the
circumstance. Right.
equipment
That has to be something that you delude yourself into believing. But I think that's an active process. I believe that. And I think really the point is we don't do a very good job, our community at large, from the hospital medical credentialing, and their board to, there's just no oversight. The oversight is inadequate. And then when there is a concern, we all know what they do. They say, it may really be a good idea for you to resign your privileges. And they do. And then they don't have to say their privileges were revoked, so it doesn't raise any red flags. They just left for other reasons.
And they move on.
It's never brought up. So they're able to leave one community after causing all of this destruction to another community where they cause even more destruction, to yet another community where they go on to perpetrate more destruction and mayhem. So, I think we have a real problem. I think we have a serious problem with how these matters are addressed, because there's the unwritten word. It's just like law enforcement, that thin blue line. It exists in medicine as well. And I've seen it. I know you've seen it. I know you've seen it. So I'll tell my story while we leave this poll up, and then we can address all of these things that come with it. So you're going to work, and you're working with a surgeon, and actually you're not even working with them. You're in another room. And the surgeon is doing a robotic wedge resection of a lung. Pretty relatively easy operation to do. But we all understand and know that there's a lot of structures in the chest that you have to be somewhat careful of, okay? So all of a sudden, and out of the blue, there is a massive blood loss occurring. in the chest where the robot is located. You're called and you rush into the room and you see that there's a pool of blood on the floor and the patient is in dire straits, and this person wants to put the patient on ECMO. Why? No, we need the heart-lung machine because you need to be on sucker bypass, right? But we get the double whammy. It's, I'm the doctor, I said what I wanted, get it. So you get the ECMO. Now, the patient is still losing massive amounts of blood, in fact, is exsanguinated. And they put the arterial cannula in the femoral artery.
Nothing comes out.
No, it sucks air because their arterial system is so collapsed. It actually drew air in. And there was no way to fill it to connect it. But it got connected anyway, and VA ECMO was initiated. But flow could never truly be established. And everything getting pumped in is getting pumped out, but now you're in full cardiac arrest. Ultimately, the patient expired. Now, this is where it gets tricky. They went to the patient's family, who, because of exceptional bedside manner, told them that during the wedge resection that the tumor released these very unusual toxins and it paralyzed the patient's arterial system, blood vessels, and there was no way to continue to maintain a blood pressure. And I'm so sorry, but they didn't make it.
That doesn't sound like what you
And
said.
it was allowed to pass. It got through. Now, in my opinion, that person should be go to the next section of the tape. Because this is what can happen. But what bothers me about this is that they waited so long. Because there's a slew of patients that this guy did things to. But wait till you see what happened to this fine neurosurgeon. Go ahead and play it.
This once prominent neurosurgeon will spend the rest of his life behind bars.
Confinement in the Institutional Division of the Texas Department of Criminal Justice for life.
The charge, intentionally maiming patients.
A medical license does not keep you from prosecution if you maim and kill people.
Emotions ran high outside court following the life sentence.
This will not bring my mother back, but it is some sense of justice for all of the families, for all of the victims.
Caitlin Lenuff's mother, Kelly Martin, bled to death during back surgery performed by Dr. Christopher Dunch, who in TV commercials billed himself as the finest neurosurgeon in Dallas.
Our next best doctor is neurosurgeon Dr. Christopher Dunch.
Mary Efford says the doctor's botched surgery on her.
In the state of Texas, I can tell you right now, and you're a Texan.
Yes.
You have to have an awful lot of compelling evidence to put a neurosurgeon in prison with a life sentence. That's pretty hard to do. And I will tell you, it still bothers me to this day.
Me too.
That I didn't do more to stop that person.
I mean, ethically, we should be doing something, but what's your avenue? How are you going to do it?
It's going to destroy your career.
Right.
It will destroy your career. You have to be willing to literally sacrifice yourself to save your fellow humans. And I was too much of a chicken to do it. But what about all the other guys, all the other guys and gals, physicians that work with this person, that knew?
Yeah, you're not the only one.
Right.
Yeah.
Nobody ever asked us.
That's true too. but do they have to ask?
Well, do you think that for most, especially larger hospital systems, I mean, they're reviewing these cases, and if a pattern develops of continual bad outcomes, they're going to do something about it today.
They did, finally, but in such a way that it allowed this person to go to another state and just do it there.
Yeah.
There's the problem.
Well, and that's, I think we see that. We all see surgeons, whether it's, you know, within our field or just we know about them in the hospital. They come from somewhere else. They're here for a little while and then they just go away.
Yeah. But what's so disappointing in that to me is that you know they're able to and are allowed to do that, and they're given this deference of, look, we really don't want to ruin your career, but you're not really a good fit here anymore, and you really need to go. I mean, no, you're incompetent and shouldn't be doing what you're doing. It doesn't mean you're a horrible person. It doesn't mean that you're a bad doctor. It doesn't. You might be a great doctor and a horrible surgeon.
Yeah.
You can also be a great surgeon and a horrible doctor. But you can also be both. You can be a great surgeon and a great doctor, or a horrible surgeon and a horrible doctor. All of the
and
possible,
a horrible person.
And a horrible person to boot. Exactly. That's exactly. But you know what really bothers me more than anything is the patients, unless you're in medicine, unless you know somebody in medicine, you don't know.
Right. They trust that if you're a doctor, you must know what you're doing.
Right. No, they trust that the system would not allow you to operate in this established, incredibly well-known facility if you weren't the best of the best. And there is the problem.
Right.
But then, of course, if we flip it over, flip the coin, and we say, okay, I know some surgeons that have had some really crappy outcomes, but man, they were given dog poop to start with.
Yeah.
In other words, the guy that gets referred
5 times.
All the crap. He only gets the crap. He gets this stuff that already starts with a 30% mortality, and other guys are turning them down.
Right, that's what I meant.
So, right.
5, he's already 5 turn downs, and there's the guy who gets left with it.
Right. Well, willing to take on the situation.
Right.
You know? So I think that we have to be careful with, you know, identifying things for what they really are. But at the end of the day, what do you do? Going full circle like we did back with the first one. What do? You're a young perfusionist, just graduated from Perfusion School, and you take a job at Hospital X in City Y, and it's your first job, and you're excited and everything. And the perfusionist that's been there for a while, surgeon been there for a while, they bring in another surgeon. The one surgeon's going to retire. They bring him in. He starts working, and he is a disaster. And his outcomes, you went from doing cases where you were on pump for 45 minutes to an hour and a half, maybe 2 hours on a tough case. You know, you had the odd case like we all get, everybody gets now and again, where you can't wean them off and you got to work with them for a while, or you end up doing a triple valve 4-vessel CABG, some big operation you're on pump for a long time. But you're predominantly speaking, you're working with very competent people that are doing a really good job, and you're basically doing good cases with good outcomes, and you feel like you're really learning a lot. And then that person leaves, and this other person that comes in is the guy that I just told you about.
I don't think you have a lot of options, especially as a new perfusionist.
But if that's happening, how much liability are you now absorbing? How much are you saying by continuing to work with this person when if there ever ends up being a lawsuit, and you're sitting on the witness stand and somebody says, do you have any firsthand knowledge of Dr. X's outcomes? Well, yes. Would you consider them to be good? Well, I guess you could argue, well, it depends on what good is. Okay, well, compared to other people that you work with. No. Well, this story, this situation, did this ever happen? Do you remember this? Yes. 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 Are any of these 4 things that I just mentioned to you, do any of these things seem normal to you? Do you consider this normal? And you're being truthful. No. So you really don't think that he was a good surgeon. You think that he really probably shouldn't have been doing heart surgery. Is that what you're saying? Well, I'm not a heart surgeon, but I'm not asking you that. In your opinion, from your perspective, you work with a bunch of them. You've seen a whole bunch of them. You were in school, 3 years ago? You've been here for the past 3 years as well. And you've worked with all these surgeons. You know whether or not, there's something wrong. Was there something wrong or not? Well, he had a lot of problems. And you still decided to work with him. You still decided to do his cases, didn't you?
Don't you think you should draw a distinction, though, that if you're working for an institution, you are doing what the institution, you're doing the cases.
Absolutely, but they'll hang you to make, because now the institution has the financial burden to pay that settlement. But they have no qualms whatsoever about taking you out with everybody else. They're going to nuke you because you don't have the money, but the institution does. So they'll go after you and get a settlement. They'll go after the institution itself and get a settlement. They'll go after the doctor, get a settlement. So that's how they do it in order to maximize the amount of money that they make.
What do you think, Mike? I think it's an impossible situation.
We don't get to pick and choose our patients. That belongs to a surgeon and a risk management team of a hospital. So in that situation, I would pretty much just say, you're looking at the wrong person. That's the person you need to be looking at. I'm there to do the best job I can with whatever I am given. And even in that scenario, we did the best job that we possibly could. We, because of what we did and what we could do, should feel that in any situation, we're going to be exonerated from any wrongdoing, because there's really nothing that we did that was wrong. And
except do the case.
Except do the case.
How much time? Now you've been around the law, so you probably have. You may have. Have either of you spent any time, let's say, first on the witness stand?
No.
Not on the witness stand, but I was at a deposition.
Okay, so you've been at a deposition.
Deposition, yes.
So depositions are similar, but a little bit different. Similar.
Close.
Have you ever spent a lot of time on the witness stand? Everything you just said to me, as soon as you started talking, there's going to be an attorney in your face saying, he's unresponsive, Your Honor, shut him up, answer the question. And they're going to ask the questions the way they need to ask the questions to get you to give them the answer that they want.
Sure.
So that's what'll happen. You won't ever have an opportunity to explain yourself. Because they're going to just go right after it. So you say you'll be exonerated. I disagree. They won't exonerate you.
So what do we do?
You'll be equally culpable. What do we do?
Yeah.
Wow. Great question. Once again, I think my solution to both of these things is quit.
Right.
Quit. But life is too short to work with somebody who is incompetent and is hurting patients.
But what about your ethical responsibility? I thought we were addressing that to preventing that person.
And then report it. And then report it. I think you have to report it. You report it to the state medical board, and then you let them do what they're going to do. I don't think you go pitch a tent outside the hospital. That would be a ridiculous thing to do. But I do think you have a responsibility to report it to the hospital and then to the state medical board. But I would highly suggest, I think I would recommend you stay longer with a surgeon or practitioners that you're working subordinate to for a longer period of time and try to correct that, then I would suggest you stay in this situation where you know this person is absolutely incompetent.
So
I am going to quit.
see if you can maybe resolve or at least make the difficult personality surgeon relationship better.
Yes.
But if you know you have a bad surgeon,
It's worse. I'll take a jerk who's at least decent at what he does and gets through the cases, and I only have to subject myself to his misery for 3 hours a day.
well, because
I can do that.
You can also still take pride in that you've helped
Yes.
a patient. Whereas if it's the other way around,
I'm participating in a sterile autopsy, and on top of it, I'm enabling this guy to get paid for committing essentially a level of homicide of some sort. Yeah, I don't want to be a part of that. Got to walk away from it. Got to walk away.
why do you think that happens? Because of there's no oversight once someone graduates to see if their skill is at an acceptable level. I mean,
I think there's a lot of surgeons that graduate from school from programs today who have never actually ever sewn an anastomosis on a coronary. There's some that have never even, they're allowed to assist, they're allowed to watch, they never actually do a case. The first time they actually sew a complete circle
they're on their own.
is when they're on their own. So you get a new grad that comes out, and if he has bad mentorship, he may never, some of them are just good. They're good.
Yeah.
You can make it that long, you're good, and they become good. But I would say any new surgeon less than 2-3 years should have very strong mentorship.
I've worked with a brand new surgeon before, brand new meaning on his own, brand new. And there was a learning curve, but he had strong colleagues that were there assisting him,
Yes.
and seeing that growth in even a year was
Yes.
phenomenal.
If they're right, if they've got good hands and they have good judgment, and they have good mentorship when they're on their own now, you can take somebody who was good and make them phenomenal. Some of them are just because they really are phenomenal. They just needed that experience to get that. And so, but
the same could be said for us. I mean, some people graduate and you hear about them later, and you're like, wow.
I know.
How are they practicing?
I know. Both Mike and I know. But unlike...
It's easier to get rid of us. A hospital, I think, has less issue getting rid of us and making it known that this is not a good hire somewhere else.
Yeah, you're probably right.
Just like a nurse or
because physicians, of course, will sue, and of course they will argue that this is subjective, and then they will argue some other things, and they'll sue for defamation, and so hospitals are afraid of that. But and I understand that. I do. I can actually feel empathy towards the other half of this equation when you're dealing with somebody who's truly incompetent because of the way our legal system is designed. But I think we need seriously to reassess that, because what I'm afraid of is right now there's a shortage of cardiac surgeons. There's a shortage of perfusionists. There's a shortage of healthcare professionals, period. The way that's going to get solved, I fear, is by lowering the bar to entry and the standards for completion of your program, and we're not going to see an advancement in these practices. We're going to actually see a decline.
I think that's proven throughout medicine for many, many years, that they go through these cycles like this, and this is exactly what we get. So, hope not. I mean, it makes you want to make sure that when you bring somebody else on your team, that they've been out there for a while. They've got some experience, you know. And it's not to knock a new grad, because those new grad. I was a new grad at one time. You were a new grad, you know. And we were fortunate to get into a situation with some good surgeons, good mentorship, and we learned, and we go from there. And gosh, that's what we could offer.
But look at what we did. How many cases did you do before you graduated from Perfusion School?
I did 600.
600.
Right.
That's more than some people have done in a whole career.
I did nothing like that.
How many did you do?
Somewhere around 130, 150.
Still 130.
Part of that was staff for about 6 months. But my student was right at 250 cases.
Okay, 230, 250. I did probably about the same when I came out as well, somewhere around there. I was actually, I was a competent perfusionist when I left my training. But I know what they're doing for training these days.
Is it less cases?
Well, there's a program where they don't do any hearts. All they do is watch ECMO. And if they see 5 hearts in their entire training, I'd be surprised.
Well, I haven't.
And they're graduating and being sent out into the workforce.
I have a problem with that, with even certified perfusionists who all they do is ECMO, and then...
Come on. Tammy, why are you being hard on me? Okay,
No,
I'm breaking my career.
I'm not.
All right, if it wasn't for ECMO, I'd be in a lot of trouble.
Well,
Come
but
on,
I don't...
give me a break.
No, but listen. Initiating ECMO is like going on pump, so I'm not talking about that.
I do a lot of those, an angiovac.
Yeah, I'm not
I might not do as
about
many hearts as everybody else
and
these
that's
days,
fine.
but, you know.
But you're not trying to do hearts. You're doing, you could.
I do under supervision, okay? So I'm gonna tell all y'all out there, I'm 41 years of doing this job.
This isn't directed at
And
you.
That's okay. I feel like it is, but that's okay. I can live with it. I can handle this. 41 years. But I don't do nearly as many cases as I used to do. And I used to always pride myself. I always wanted to be the best. I never really was, but I tried really hard.
You did your best.
But I did my best, yes. But now, when there is a heart and I come in and say, hey, can I do this case? But don't go too far, okay? Somebody stays around and kind of monitors me and just make sure that I don't do anything to get into trouble, which makes me feel a lot better about doing the case. But, I think that because I can tell you, when you don't do as many cases as I used to do, when you're not doing, the minimum is 40. I gotta tell you right now, if you're doing less than 100, maybe 80, I'll knock it down to 80 just for the discussion. I tell you right now, it's you don't feel comfortable.
Well,
I don't.
I don't feel comfortable when I come back from a long vacation.
Yeah.
That first case.
Or if I've been doing a lot of ECMO for 4 or 5 days, when I get back, it's almost like there's that little bit of me that goes, remember that, remember to do that, remember to do that.
Yeah.
Well, my point is about this.
What about coming back from vacation and the first case you get to do is the guy I was telling the story about? Back on vacation.
My point is if there are perfusionists out there that are just going to monitor ECMO, they're not initiating, they're just monitoring.
Yes.
I think there should be some kind of requirements, whether it be simulation. Maybe they don't have the opportunity to do other cases, but some kind of requirement to make sure you stay hands-on.
Yes, it does make a difference. It does. There's so much that happens. It's like being in the, even though, what's that guy's name? I forgot his name now. What was the guy that was in charge of perfusion services in Psychor? Dunaway, Mike Dunaway. Mike Dunaway, okay? I don't know if he was still alive or not.
No, he's passed away.
He died?
Yeah, he passed away.
But Mike he was kind of the guy that associated what we do with flying. Only flying a sophisticated aircraft. Now, we're not talking about a little Cessna 140, okay? We're talking about a sophisticated aircraft. And it is kind of like that. You're in the cockpit, and you've got this happening, and that happening, and this happening, that. There's all these things and you're constantly looking at things, but yet to the casual observer,
Yeah.
You're
You're
just
not
sitting
doing,
there.
you're not doing anything.
But they have no clue all
Yeah.
of the various things. And when you, like you said, a long vacation or a long hiatus, let's say you're out for 3 months, you had a baby or something like that, you come back, and that first case, just doing the stuff from the beginning, the preparatory work. That's where I really have a problem. I almost can't do it anymore. I need somebody to help me just get the preparatory work done.
Right.
The mechanical part of going on pump, doing the case, giving the pledge, down on the flow, up on the flow, checking the gases, doing the various things that we all do, the pressure, all the stuff that we're doing all of our cases, I still feel pretty good about. But it's all of the other ancillary peripheral things that are expected of us to do, that if I have to do that too, I can't focus on both. I have to just focus on this portion of it.
Not the point of care and all of this stuff.
Can't do it.
Yeah.
I can't do it.
Well, even, before I came to HET, I worked somewhere for a long time with surgeons that I'd worked with a long time. I knew their routine.
Right.
I didn't have to think about it. I knew it. And even when those situations where you are completely comfortable, you're out for a period of time. I was out for an illness, 10 weeks, came back. I wanted someone to shadow me just because I was like, even though I've been doing this a long time.
That's smart. There's a lot of people that wouldn't do that.
It's always struck me that we have one of those jobs that to really be good at it, you have to be a really good multitasker.
Yes.
I mean, you gotta
and quick on your feet.
See one thing, hear another, and do the third, and be thinking about what you're going to be doing the next one all at the same time.
Right.
Yes.
And it's hard to get to teach that.
It's very hard.
And it's hard to master that. And I think, to your point, you were talking about earlier, the amount of cases that these young perfusionists are getting in training. I mean, like I said, once again, I'll clarify my answer. And as I was a student for 1 year, I did 250 cases.
That's a lot of
cases.
cases.
As a staff person for 9 months, 6 to 9 months, about right at 9 months, I did 350 cases. So I did 600 cases in 18 months.
Before you took your boards.
Before I took my boards. Now, there wasn't a lot of deviation in what we did, but I mean, there was a lot of, that gets you to get those things done. You can't, if you're not a natural multitasker, you can't train that getting 30 cases in a teaching institution.
I don't think you can train it doing any number of
boards.
cases, frankly.
I don't think you
and
can
I
do
think
it.
that's what separates the good surgeons, the good nurses, the good perfusionists, the good anesthesiologists, the good intensivists from the ones that are either mediocre or shouldn't be doing it at all.
Even the same thing you do every day, you learn how to make that quicker, more efficient. Prioritizing on pump is one of the biggest things. You can't do everything all at one time. You better figure out which one's the most important thing to do first.
Exactly.
Right. Exactly.
So, exactly. Yes, there has to be a logical progression.
And you have to get number one goes first, and then number two, number three. Number three is not that important until you get number one done. You screw up number one, there ain't gonna be number three. So I think that's the roughest part to what you're speaking at is that these guys and girls, they just haven't had a chance to do enough to get that routine down.
Yep, I agree. I agree. So, okay, any final thoughts? Mike, words of wisdom.
We're back to the original topic. I think Joe summed it up pretty well. Try to make things better with this person who is difficult to work with. If that doesn't, go to your immediate manager or go up the HR ladder. If that doesn't work and nothing's going to get better, like Joe said, sign on. There's other places that I know my skills are going to be appreciated. That's where I'm going.
I think that's great points.
Okay.
Miss Tammy Sparacino, Mrs. Sparacino, if you will.
All good points. I just want to touch on a slightly different point that I think will help you achieve that is be receptive to other people's thoughts about things that you can do better. Because just because you have your perfect routine, especially when you're new, or especially when you're old and you've been doing it that way all the time, if you're receptive to other people's ideas, it's because sometimes certain things work better in certain environments, and you can, look at it as an opportunity to improve yourself.
You can always get better.
Right. And that also, I think, garners trust with your colleagues.
Yes, and you need that.
Right.
So to add to what you just said, if I may, and then I'm going to mention what Praveen said, because we may not be quite ending yet, because this is a really good point, is that when you finish school, when you get out of training, please don't go to your new job and say, well, I didn't do it this way when I was in school. Nobody wants to hear that, and it's going to really make everybody angry with you. So that's the first thing you don't say. The second thing is when you've been doing this for some time, and you do have a particular way that you do something, let's say changing an oxygenator on your ECMO patient, okay, who's on VA ECMO and is fully dependent on the ECMO. So when you clamp those lines and somebody hits the clock and it's ticking, and you see that patient's pressure just go down to nothing, and the stress starts kicking in, that is not the time to try to do something a new way.
Right.
Okay, so pick the time. So just my 2 words of wisdom are that, okay? Never try something the first time unless it's a crisis and you have to, on an actual living, breathing human being that may be under anesthesia but should walk out of the hospital, okay, with all of their cerebral capacity that
And
you can
don't be
preserve.
afraid to say you don't know how to do something.
Yes, or don't be afraid to say, no, I'm not doing it that way. This is how I'm going to do it. When it's your case, when it is your case, if somebody talks you into doing something that you're not comfortable with and you allow them to talk you into it and it all falls apart, it's on you.
That's right.
Your case is your case. That's it.
Right.
So, because it's all going to fall back on you. Because I come in there and tell you, oh, just do this. No, I don't do it. I don't like that. I want to do it like this. And I talk you into doing it my way, and it all falls apart, and you're doing the case, you're going to turn around to say, Joe told me to do it, only Joe's not going to be in the room.
And Joe's not on the record, and
I'm
Joe
leaving.
won't go to court.
Joe's leaving. Joe's out.
Yeah.
Yeah, I don't remember saying that. I don't recall.
Yeah.
Okay, I don't recall. So I'll throw you right under the bus. Praveen says that we should have simulation labs for human interaction in stress situation and complex environments. It's a good idea.
I think it is a great
I
idea.
like that idea.
I like it.
Yes.
Yeah.
I think we should do that here in the studio. I think we should do like a thing where, Tammy, you're first, and you're here in the hot seat, and we all stand around, and we just start firing stuff at you to try to see how much we can stress you. And then we'll have shots of tequila, and then we'll start doing it again, and we'll see if there's, like, maybe we'll learn eventually that a little shot of tequila before your case could actually benefit. What do you think?
Okay.
Is this not going too well? That's not happening too well? Or we could put people under stress and do their microvision scan.
Yeah, let's do their
Microcirculation.
microcirculation.
That might come out
See how many white
interesting.
cells we can see. That'd be fun too. Okay.